Greetings. My name is Nancy Reynolds. I'm a professor and Associate Dean of Global Affairs at the Johns Hopkins School of Nursing. It is really my pleasure to be with you today, and I thank you for inviting me. And I bring you greetings from the Johns Hopkins School of Nursing. So I was asked today to discuss a recent paper that I co-authored with colleagues at the Johns Hopkins School of Nursing. So today I'm just going to focus on a summary about the background that informed this paper, the methods we used, the results that we found, and our recommendations. So the paper focuses on COVID-19 and implications for nursing and healthcare in the United States. And we prepared this paper by bringing together a group of faculty at the Johns Hopkins School of Nursing who held an interest in this area. And we were responding to a call by the Journal of Nursing Scholarship for papers addressing policy implications of COVID-19. And our interest was really in looking at this in more depth in the United States. The outbreak of COVID-19 was declared a public health emergency of international concern by the World Health Organization on January 30th in 2020, and a pandemic on March 11th of 2020. Now, more than 3 years into COVID-19, the world has been presented with many well-documented challenges, including death, disability, and socioeconomic damage. In fact, in May 2022, the WHO reported the very grim statistic that an estimated 15 million people worldwide have died of COVID-19, with 1 million of these deaths occurring in the US. And really throughout the world, we found that health systems were unprepared for the pandemic, despite years of warning of public health experts who warned us if something like this occurred, that we needed to be prepared. Health crises such as the Ebola epidemic and now COVID-19, acutely illustrate the need for resilient healthcare systems that can prepare for and effectively respond to crises while maintaining their core functions. A robust, resilient healthcare system should provide the right services, both personal and population-based, in the right place at the right time to all those who need the services. Although the United States spends far more on healthcare than any other country in the world, the COVID-19 pandemic severely strained hospitals here and health systems across the nation and really undermined the health of the US population. While the US has not been the only country to endure painful challenges and losses from COVID-19, the pandemic really highlighted deep socioeconomic inequalities, communication and workforce challenges, and weaknesses in the US healthcare delivery systems. It also showed the incredible importance of nursing to healthcare systems. Although the COVID-19 pandemic has highlighted deep underlying problems in the US, it also really provides us with an opportunity to reflect and to consider how to facilitate improvements going forward. So in our review, we used the World Health Organization system building block framework and the socioeconomic model to guide our study, and we developed then an adapted model that combined and expanded these models. And to explain the model a little bit, Healthcare systems that can deliver services equitably and efficiently are critical for achieving improved population health. And in an effort to support health system strengthening, the WHO Health System Framework identifies 6 foundational building blocks of a strong, functional healthcare system. And this includes service delivery, health workforce, information, medical products, vaccines and technologies, financing, and strong leadership and governance. In considering health system strengthening within the context of COVID-19, the WHO Health Systems Framework can be viewed from a broad socio-ecological context as delineated in the socio-ecological model. Within this framework, dynamic interrelations among various personal and environmental factors are represented, with the recognition that no single factor can explain or predict a particular phenomenon. As such, lessons of the COVID-19 pandemic can be viewed as the outcome of dynamic interactions between discrete but interrelated dimensions at the individual, such as patient, families, and nurses, interpersonal, the relationship between patients, family, and healthcare providers, including nurses and their co-workers, organizational, the context of healthcare practice within the organization, community, including nursing communities, professional and educational regulation and standards, and then public policy, the socio-political and economic level. So guided by this framework, we used a modified Delphi technique. We convened a panel of experts who had relevant research and clinical backgrounds to really define and discuss the problem area, analyze the literature, and bring together explicit and implicit knowledge with the goal of reaching group consensus on the domains of importance, lessons learned, and policy implications. The domains of interest that we identified were based on a review of relevant literature across nursing, public health, and policy journals, followed by extensive discussion and triangulation within the integrated frameworks. A facilitator led the discussions with the panel of experts. And after each round, the facilitator summarized the range of experts' judgments and rationale provided. And then at the start of the next round, the discussion from the previous round was reviewed and rationale for the experts' earlier judgments were reviewed. And then this information was then provided to the expert panelists who would revise their previous responses based on the replies of other members of the panel. This process continued to reduce the range of responses with the aim that the group would ultimately converge towards a consensus. And then the process concluded when convergence of opinion on 4 domains and their interface with the integrated model was reached. And we recognize that this is not an exhaustive list of potential topics, but we agreed that these domains were the most salient in the literature and the nursing clinical practice to date. And they really offered excellent opportunities to highlight interacting concerns for policy change. So the 4 crucial intertwined domains that have influenced and been influenced by healthcare delivery in the United States during COVID-19 that we identified were social determinants of health, mental health, communication, and nurse workforce. Social determinants of health are identified by the World Health Organization as the non-medical factors that shape and influence health outcomes. And these are the conditions in which people are born, live, work, age, and the wider set of forces and systems shaping the condition of daily life. These conditions are typically grouped according to economic stability, education, access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. The social and other health determinants occur in feedback loops throughout the life course, intergenerationally, as well as at the individual, population, and community levels. Over the past few decades, the studies of the social determinants of health have revealed stark health-related disparities by race, and then ethnicity, age, and gender and ability. Unfortunately, in the United States, the COVID-19 pandemic further exacerbated existing health disparities. In society's most vulnerable communities were disproportionately affected by COVID-19. And this included Indigenous and Black and Hispanic Americans, older adults, children living in lower socioeconomic households, pregnant and postpartum persons and their infants, and incarcerated persons. Black and Hispanic adults in the US were 2 or 3 times more likely to report household food insecurity, and they were more likely to report job loss and difficulty paying household bills compared to white adults during COVID-19. And recent rises in inflation in the US have also disproportionately affected the finances of communities of color. Additionally, patients in the US are more likely to face higher out-of-pocket costs and to be uninsured than those in other comparable countries. And really, the pandemic compounded physiologic and social vulnerabilities at those of high risk across the lifespan. And we found that older adults faced disproportionate mortality during the pandemic, which was unequally distributed by race, ethnicity, and indices of social vulnerability. Further, the required social isolation that aimed to protect older adults from infection was also linked to loneliness and depressive symptoms, especially in long-term facilities. So older adults were more likely to experience comorbid conditions, delayed seeking health services for non-COVID related health problems, or were unable to access these services because of overwhelmed providers and healthcare systems. And while children experience comparatively lower mortality compared to adults, COVID-19 was a leading cause of death and severe outcomes for this population as well as significant racial disparities. Pregnant and postpartum people and their infants are another group whose physiologic vulnerabilities to the virus were compounded by fragmented policy environment that failed to adequately consider their unique needs that led to barriers to care and labor support and mother-infant separation, which has negative psychosocial impacts. There were also severe inequalities for incarcerated people who had inadequate mitigation measures and delayed vaccination rollout compared to other groups. And this led to a much higher incidence of mortality and morbidity than the general population during the peak of COVID. So taken together, Existing inequalities in the US were greatly exacerbated by the COVID pandemic and inadequate policy response to it. And this resulted in a life expectancy decline of 2.7 years between 2019 and 2021, which really sets the US apart from all other wealthy nations. The pandemic also created a mental health crisis in the US due to numerous factors, such as the disruption of care for people with mental health needs and substance use disorders, and the creation of conditions that exacerbated or catalyzed mental disorders. By February 2021, over 40% of adults in the United States reported anxiety or depressive symptoms, and 25% reported that they were not receiving needed care. Deaths from drug overdose increased by 28.5% over a 12-month period, primarily due to use of opioids. And while mental health systems were often brought on or worsened by the pandemic environment, an actual diagnosis of COVID-19 and difficulty coping with the symptoms of the virus were also associated with depression, anxiety, and traumatic stress. The pandemic adversely affected the mental health of all age groups in the US, but children and youth who were most at risk were those with the greatest exposure to pandemic-related stressors, including COVID-related death in the family, lack of reprieve from abuse or relationship conflicts in their home, financial strain, prolonged isolation from their peers, and challenges with remote learning and pandemic-related racial discrimination. A recent nationally representative sample of US-based adolescent students found that 37% experienced poor mental health during the pandemic. 19, almost 20%, had seriously considered suicide, and 9% actually attempted suicide during the pandemic. The social distancing protocols of older adults were also linked to loneliness and depressive symptoms, particularly for residents of long-term care facilities that restricted family access and required residents to quarantine in their rooms. 80% of deaths from COVID-19 occurred in adults aged 65 and above. And of course, essential workers, and of course, including nurses, really risked higher rates of exposure to COVID-19, and they also had higher rates of psychiatric symptoms compared to the general population. Frontline healthcare workers were exposed to unprecedented levels of stress, burnout, and moral injury due to suffering and death of their patients and colleagues, emotionally difficult situations with patients and family members, conflicting loyalties to their own self and family care, employers and patients' demands, and ethical dilemmas regarding the rationing of supplies and resources, as well as their own personal risk for COVID-19 infection. Approximately 22% of healthcare workers experienced at least moderate depression, anxiety, or post-traumatic symptoms during the pandemic. And nurses were at higher risk of infection and death than any other healthcare profession. And over 20% reported wanting to leave the profession. And of course, underscoring the social and environmental inequities in the United States, racial and ethnic minorities experience greater stress, worry, mental and substance use conditions. Communities with unstable housing, low income, unsafe neighborhood, and substandard education were disproportionately affected by COVID-19, as were incarcerated persons, as noted above. We also found challenges with communication. Responding to COVID-19 required critical preparedness and response, which includes effective communication as an essential strategy. As COVID-19 spread, healthcare systems in the U.S. aggressively stepped up response measures, such as finding, isolating, testing, treating, and tracing transmission to save people's lives. Media and social conversations were dominated by large amounts of information about COVID-19, of which there was initially very little known. Public health information communicated through social networks and traditional media was often inconsistent, and messages conveyed were sometimes not well received. America's vast size and decentralized government structure resulted in uneven implementation of often conflicting recommendations coming from epidemiologists, media influencers, and government officials. Policies varied by region, and mask wearing and other preventive behavior became highly politicized in the United States. Conspiracy theories spread on social media, undercutting trust in vaccines, with many persons turning to unproven treatments and avoiding being vaccinated. Nurses and other healthcare providers in both primary and acute care settings often face challenges of disrupted communications. Protective measures against the virus, such as face masks, hindered their interpersonal connection with patients. Patients in hospitals were isolated from families, and providers needed to limit the frequency of their entry into rooms. This placed added stress on nurses in their patient care role. The restricted visitation policies required innovative communication structures and care for nurses, patients, and their family members. Also, telehealth and telemedicine became a method of choice for most consultations. In nursing education, there were communication challenges as a result of having to move from in-class lectures to online delivery. And for students without reliable internet access, this led to another disparity in their equal access to information and ability to adapt to a new educational approach during the pandemic. And of course, we found that the nursing workforce experienced many challenges. Some of these challenges really were there prior to the COVID-19 pandemic. In fact, healthcare leaders predicted that hospitals would be facing a nursing shortage. The duration, intensity, and repeated surges of the COVID-19 pandemic, though, deepened the nursing workforce shortage and cost hospitals an estimated $24 billion in USD to mitigate the staffing shortage. A recent report has shown that 100,000 nurses in the US left the workplace due to the stresses of the COVID-19 pandemic. Of course, there were a variety of contributing factors, and among these were an increased demand related to COVID-19 with surge in hospitalizations and critical care needs, unsafe workloads. The nurse to patient ratio was often very poor. Nurses also were moved to other units in which they didn't feel comfortable practicing. There was fatigue and burnout. There was an inadequate number of new nursing graduates. And of course, as I mentioned previously, increased attrition of nurses. So COVID-19 is very unlikely to be the last pandemic in the US and globally. And to control COVID-19 and to prevent prevent unnecessary suffering and social economic damage from future pandemics, the US government will really need to improve its capacity to protect public health. Complex problems require multi-level solutions across critical domains. Reforms across levels, individual to community and public policy, and interacting domains are needed, as summarized in the table that I showed you earlier, and as I will elaborate now. We think that it's very important that there be measures taken to address the social determinants of health and health disparities, actions urgently needed to strengthen prevention and access to mental health and substance use disorder care. Communication must be improved, and there must be greater investment in and support of the nursing and healthcare workforce. So measures taken to address social determinants of health and health disparities. As mentioned earlier, disparities in access and health outcomes are entrenched in many features of the US healthcare system. And when nurses recognize health inequities, they are really obligated to address those needs at all appropriate levels, including individual, organizational, and community levels. Social justice, holistic care, and patient advocacy are historically fundamental principles of nursing. These principles include addressing the social determinants of health, particularly among marginalized population. The effect of the pandemic on vulnerable communities of color and other vulnerable populations shines a light on systemic inequalities in healthcare. The problem, however, cannot be solved within the healthcare system alone. Much of the heightened vulnerability of persons of color originates outside of healthcare in differential access to education, employment, housing, and social justice, as discussed earlier. So some of the things that we think are very important going forward are policies that really address upstream social determinants of health. We think it's very important to improve agency, community, intersectional collaboration. So we think it's important to promote multi-agency collaboration among health, housing, education, and employment services. That's really needed to mobilize social support networks and better access to integrated healthcare services during a pandemic. There needs to be improved access to primary and preventive healthcare services. And this is something that WHO thinks is a key role for nurses around the globe, that we really need to strengthen the availability of nurses in primary and community healthcare settings. We also think it's important to require healthcare organizations to compare the quality of care for patients of different races and ethnic groups, and to do a reflection on how that can be improved if there are inequities identified. We think it's important to improve anti-bias and health equity training in the education and licensing of health professionals. It's important to improve screening for the social determinants of health in primary health care as a routine expectation of high quality health care. Also think there needs to be greater investment in community level interventions, again, to improve support for safety net facilities and small community providers, including inner city and rural hospitals, community health centers, that can improve access to basic and advanced services for populations of color. We also think it's important for nurses, for nursing advocacy for policies that directly address the social determinants of health. We really think nursing organizations should take up calls to action from nursing leaders in health equity and engage in the development, advocacy, and implementation of social policies that impact health. Also, and very important for nurses to take leadership on integrated pandemic preparedness policies. And again, this is something that's being recommended by the World Health Organization. They think nursing has a very important voice, and it's critical to have that nursing leadership voice be a part of pandemic preparedness. We also think that action is urgently needed to strengthen prevention and access to mental health and substance use disorder care. And this can be provided through more effective leadership for mental health care, the provision of comprehensive integrated mental health and social care in community-based settings, implementations of strategies for mental health promotion and prevention, implementation and maintenance of rapid evaluation and screening for comprehensive treatment of mental health and substance use disorders, expanded coverage for telehealth and remote coverage. So even if people are isolated in their homes, that they are able to access important and critically important mental health care. And then really prioritization of social connectedness and communication with mental health services for all age groups, families, providers, and long-term care residents. For youth and older adults especially, maintaining social connectedness is crucial to mental health, and school connectedness is key to addressing youth adversity. We also think that it's very important to improve communication. Of course, responding to COVID-19 requires critical preparedness and response, which includes effective communication as essential strategy. And it's really clear that communication must be strengthened across several dimensions. We need to create trustworthy, reliable sources of well-coordinated public health information. We need to do better to combat misinformation with the use of effective evidence-based messaging strategies. And nurses in the United States have been voted as the most trusted profession for 20 consecutive years. And we think, therefore, that they would be a very important source for providing factual and current information to the public during an emergency and pandemic. I also think messaging to the public should consider health literacy to meet the diverse needs of different communities. And also, we think it's very important to use telehealth best practices. And lastly, there must be far greater investment in and need to support nursing in the healthcare workforce. The COVID-19 pandemic has had a significant negative impact on the nursing workforce, and it's really exacerbated workforce challenges that existed prior to the COVID-19 pandemic. We really need to implement short and long-term strategies to mitigate the adverse effects of the pandemic and these pre-existing underlying conditions that are affecting the nursing workforce. Some of our key recommendations include actions to establish safety standards to protect nurses and other healthcare workers. The United States, at the beginning of the pandemic, nurses did not have access to PrEP. We need to develop nursing leadership to maintain an environment of trust and psychological safety and empowerment. We need to implement team support strategies, including communication skills and protocols to address workforce violence, suffering, and death. For example, team members could be encouraged to monitor and support each other, identify serious issues, provide peer support, and to develop a buddy system that trains workers to watch out for each other in crisis situations. And we've really found that this has been useful in prior disaster situations. We need to institute policies and interventions to support the psychological well-being and resilience of healthcare workers in disease outbreaks, including work scheduling and time off policies, supportive services for staff, and access to more support without stigma or punishment. Hospitals and other clinical agencies should address workforce stress, violence, and mental health concerns. And we need to develop educational materials and supporting learning environments for nurses and other frontline workers to develop accurate knowledge and beliefs about symptoms of anxiety, depression, acute stress, and resources available to them, and educate healthcare workers in psychological first aid. We also need to reduce reliance on travel or agency nursing. The demand for travel or agency nursing in the United States exploded during the pandemic as hospitals struggled to meet unprecedented workforce shortages. But the decreasing the use of travel nurses is really critical to provide a stable, expert nursing workforce and continuity of hospitals. It placed extra demand on the permanent nurses in hospitals when hospitals relied heavily on travel nurses who were unfamiliar with the environment and often, it placed undue stress on the nurses. We need to reset nurses' relationships with hospitals to provide them with more predictability and control. And then we think it's very important that hospitals need to really develop and other healthcare settings, mechanisms for nurses to have career development and advancement. So such as continuation programs. We think it's important they maintain RN residency programs to facilitate the transition of new graduates through education, mentoring, and acclimation to new service positions. We think we need to improve registered nurse educational pathways and training, such as improvement of tuition support. And we think schools and practice should partner to identify new models of supervision that may provide incentives for experienced nurses to serve as preceptors and clinical instructors. And we think we need to really invest in preparation of nurses for primary health care and community-based roles, as I mentioned earlier, is critical for better response to emergencies such as we've seen with COVID-19. So let me conclude by saying that COVID-19 and other recent infectious disease outbreaks have highlighted the urgency for robust, resilient health systems. We now have the opportunity to reform the flawed healthcare system that made COVID-19 far more damaging than necessary in the United States. Social determinants of health, mental health, workforce, and communication are four interrelated, critically important domains for improvement, individually, interpersonally, within communities, and in public policy reform. So I thank you for your attention, and I have attached a reference to this paper where you can find the full references if you're interested in seeing any of this information in more depth. So I wish you well. Many thanks.